biopsy could be even more relevant. Dr. Orczyk.
Yeah, good morning, dear Chairman. Thank you very much for having me today. So I'm Clément Orczyk. I'm associate professor in UCL, and I'm a focal therapist, which is probably my biggest disclosure. This is my other disclosure. So I think critically on this topic of systematic biopsies as a roadmap for therapy and focal therapy this morning, and MRI combined with MRI targeted biopsy, I think the answer is really much a function of the disease multifocality and the natural history of it, but also the MRI visibility phenomena. And I think I'm going to surprise a lot of people when I think actually we don't need it. We don't need the systematic biopsies. And I think it's all about the resolution of what you want to treat and what you want to survey and what you want for your patient. I put a little star there, and I think I will come back to it, because I think it depends where you are on your pathway to have the greatest and the best actually diagnostic accuracy using your MRI. Briefly, I will come to the focal therapy definition is to treat selectively a tumor within the gland. And the aim is obviously to maintain the benefit of whole gland treatment, sparing some functions in terms of erection and incontinence. And in this case, we are very much worried by dropping the systematic about the out-of-field recurrence, which is on the other side of the gland. So we want to treat a tumor. A tumor has been really well defined 10 years ago in this paper from Cells. There is hallmarks of cancers. For a tumor is not only cancer cells, it's everything which is around, from the microenvironment and the stroma, the immune cells, and this is, I think, very important in the MRI stories that we detect tumors. Focal therapy, so we've got here a lesion which is about the rule-in, so we want obviously to detect the disease to treat it. So if we take the assumption that we have a positive targeted biopsy in this area, we can treat it. This is a post-HIFU MRI at 1 week from the treatment. You can see the necrosis here on the right-hand side of the prostate. So we want to rule out the cancer on the other side of the gland, which is negative predictive value. You want to be able to take a margin, as with any oncological treatment. And I think, as I said initially, it's a problem of resolution. And I think systematic biopsy lack resolution to plan treatment. If you take the more detailed possible biopsy, which is a 5 mm sampling of the gland, you take a call every 5 mm of the prostate with a patient under general anesthesia, you will still miss some resolution, spatial resolution, with where is the tumor exactly. For example, if this entire tumor, you've got 2 cores positive here, the next positive core is on the left, but you will miss this part of the lesion in the middle. So it's not good enough to deliver a treatment when you want to destroy the whole cancer. Importantly, the resolution of MRI is consistent to deliver a margin around an MRI lesion. There's been a lot of work done in silico and then modeling, reconstructing radical prostatectomy specimen in 3 dimensions, doing some correlation with histology, and this is a paper from NYU from now 7 years ago, which clearly show that there is a lesion to take around an MRI lesion. On an MRI, you see most of the center of the lesion, you don't see the periphery of it, and systematically, it has been shown by many, you can take a margin around. Everyone doesn't agree on the millimeter around, but the general principle there, the resolution of MRI is enough. Can the random sampling capture significant disease? And I think when we talk about systematic sampling, there is systematic sampling and systematic sampling. I previously described a 5 mm sampling, every 5 mm, which is getting kind of a map, a roadmap for the prostate, but also the truss, the very standard truss, the random truss biopsy carries some errors, and probably the biggest one is the anterior part of the gland. And there is cancer in the front part of the gland. Going back to the PROMISE study, which was very well designed because there was the MRI for everyone, but also a 5 mm mapping, which was the gold standard, and the truss biopsy. And what we can see is clearly that systematic biopsy with truss compared to a 5 mm mapping miss half of the significant cancer, which is huge. If we compare to MRI, still also from the PROMISE study, MRI detect 5 more times, the TRUST biopsy missed 5 more times the numbers of significant cancer compared to MRI. So MRI is far better in ruling out cancer. But the added value of systematic sampling, in the case of focal therapy, we want to know the foci of cancer outside of what we're going to treat. But there is a systematic value which has been done in this paper, which is a systematic review from Connor in UCLA. And they show consistently that the added value is actually not that big. It's around from 1%, 7%. This has been shown also in the Cochrane review back in 2020. But what is very interesting in this paper, from me, I told, which is UK-based multi-center studies, like actually, if you had systematic biopsy, you will miss, if you don't do a systematic biopsy, you will miss 18% of additional foci. But probably the best detailed study has been done in San Rafael in Milan. In this paper, they look at exactly what you're missing if you don't do the systematic biopsies. So in those cases, if you do a targeted biopsy and then you don't do the standard systematic TRUST, you will miss 30% of what is called significant prostate cancer. But they did the great job at looking at how much do you miss. And then if you take the Gleason 7, the mean size of what you're going to miss is 3 millimeter. And then they stratify it by Pyrad score, Pyrad 2, 1.8 millimeter, up to, in Pyrad 5, a mean of 3.8 millimeter. And if we go back to the very definition of significant cancer, it's not only about the grade, it's also about volume. It has been clearly defined since probably 2 or 3 decades, and probably we need to revisit those definitions, that you need 0.2 cc of a lesion with pattern 4 to be significant. So they show that clearly MRI resolution do not capture low volume of the non-dominant insignificant disease. So what happened in terms of resolution if we go from the very high resolution with the transperineal mapping biopsy at the gland level to more targeted approach? And this is what happened in focal therapy when you do that. And this is the story from UCL in terms of focal therapy. It's a study which has been published now in 2018 with 1,000 men undergoing HIFU, and you can see that the population is going from 2006 to 2017. And actually, at nearly 10 years, so look at the numbers, it's 59 patients there, so I'm not saying that everything is perfect at 10 years in focal therapy, it's not my message, but we've got only 20% of patients transitioning to radical treatment, which means if we left behind something, it didn't push to go for radical treatment. And in this population, even we get better. So we did less intense sampling, more MRI targeted biopsy, and actually the rate of retreatment decreased across time. That's because we were getting better at diagnostic because we learn, and this is probably one of the biggest messages. There is a learning curve. Can the resolution of the MRI visibility help to discriminate truly significant disease? And the answer here is probably from the active surveillance cohort. In this active surveillance cohort from UCL, 600 men for up across 5 years, there was a clear split between the patients who had visible disease on the MRI, 3+4 visible, and the non-visible. And this is about metastatic status. Clearly, the Kaplan-Meier is flat for non-visible disease, and there is some metastatic disease in visible disease if you miss the window for treatment. So visibility is important, and MRI has the ability to capture it. Very interesting there, I think, a paper from this year from Rochester in New York, in the New York State. They compare the recurrence rate after radical treatment if the patient had only invisible disease or visible disease at targeted biopsy. With the same grade here on this Kaplan-Meier, if they had non-visible disease, there was no recurrence. And it's actually quite rare to see that in oncology, a flat Kaplan-Meier. If a targeted biopsy, there was some recurrence, meaning that the risk of the disease are clearly different. Do we have more molecular basis about the visibility phenomena to stratify the disease? And I put in parallel those two papers, very recent, and they have been very well done. I don't understand personally every single thing they've done, especially with this very nice technique of single-cell spatial proteomic. But clearly, they said that the invisible MRI disease and the benign tissue shares the same proteomics, which means that the very expression of the DNA is the same if you don't see a cancer and benign tissue. Not a lot of patients, but I think this is probably what we have observed in our active surveillance cohort and focal therapy cohort. I put a start on my no at the start of it.
Excuse me, you need to move quickly to conclusion, please.
I'm there. I think the start is about like how we can get better at MRI and have a better quality of MRI, and this is about training people on the pre-qual score which has been developed. Is this still a roadmap? I think the resolution of MRI enabled to define the target for complete ablation. The resolution of standard systematic biopsy is low. The resolution of the MRI visibility phenomena is set to detect truly significant disease. The resolution of MRI enables oncological control with focal therapy, and we can optimize MRI. I think the roadmap for a patient-centered treatment in the form of focal therapy needs systematically a multiparametric MRI. Thank you very much.
So thank you very much. I think that the initial session gave you a lot of information to go back home and modify the way you are assessing your patients. The next session is interesting. The title is Should PSMA plus MRI Guide Treatment Algorithm in High-Risk Prostate Cancer?